Right. Thank you. Happy New Year. Let's go ahead and get started. Thank you for joining us for our medical advisory and medical provider updates for the first week of the new year. Hopefully you can see my screen here. I'll blow it up a little bit. I'm just going to share, and obviously I will send this out so that you have access to all of these hyperlinks. But I'll just start with something that I didn't get to cover last time, and that is, there's been a lot of movement and response to the Omicron surge at the federal and state level. And so I just wanted to review those and put these on your radar. Hopefully they're already on your radar, but if they're not, hopefully this will help catch you up. So first, as you'll recall, back in July, Dr. Aragon with the State Health Department created a vaccination mandate, really affecting all healthcare staff in all facilities. Well, that vaccination mandate has now been updated to be a booster mandate, in recognition of the fact that boosters are indeed very protective and very necessary with this Omicron surge. So basically, depending on whether you're at a hospital, a skilled nursing facility, or intermediate care, the language has been updated to reflect the fact that your staff need to now have boosters. Then the quarantine and isolation for healthcare workers was also updated. This was really done in response to the fact that the CDC updated their Q&I for healthcare. And so now they kind of speak the same language and have the same timeframes. There's a few differences here and there, and I'll just leave it to you to review which ones of these apply to your organization. But pretty much they've been able to shorten the quarantine time from 10 days down to 7 days with an exit test. Otherwise, they break people out into risk levels based on the type of exposure and then the type of work that they're doing and then the type of worker, if they're immunocompromised or not. And then there's some different sort of recommendations / guidances for the kinds of activities that they're allowed to do and the kinds of masks that they have to wear, et cetera. Third, visitation policies have had to change a little bit as well. And really, visitations are still kind of mandated at the national level. And so you still have to have visitation policies in place. But, in recognition of the surge, and I'm talking about like for residential settings like skilled nursing facilities and intermediate care and things like that. But for visitation policies, now with this surge going on, they're actually requiring proof of vaccination and or a negative test for visitors. So look for the visitation policies updates if you need clarification on that. And then just now, I haven't even had a chance to look at this, but the CDC, because they got so much backlash and there's so much back and forth about what the CDC has been doing, they put out a pretty long, nice science summary of why they changed the Q&I criteria. So if you're getting curious about that or getting questions about that, you can look that up as well. So again, lots to read in your spare time, but hopefully things that, this is just a quick reference guide if you need to find these items, if they are pertinent to what you're doing. All right, let's go to metrics. So this is a graph which is even more concerning, growing ever more concerning every day. So this is basically the R effective for California and also for Fresno. We are in line with the state, and the state is basically really getting its butt kicked by Omicron in terms of the number of new cases. So when the R effective is greater than 1, we know that spread is likely. And when it's really closer to 2, we know that it's basically exponential spread, because every one person infects 2 people, those 2 people go on to infect 4 people, those 4 people go on to infect 8 people, et cetera, et cetera. So that's why it just mushrooms whenever the R effective is close to 2. And that's basically what's happening. Some areas are actually up to 2. Like Los Angeles actually went over 2 for a couple of days in the last week. And so it's very concerning to see that our numbers are also trending up to where our R effective is now 1.5. And so for every one person who's infected with the Omicron variant, right now they're infecting 1.5 other people. And then that is basically just going on to create more and more cases. Now, those are cases, remember. With hospitalizations, again, I wish the news was better, but it's not as bad with hospitalizations yet. So hospitalizations are now trending up at quite a clip. They're up at around 252 countywide. They're probably going to go up to about 400. This says 300. Yesterday it said 400. This projection varies, but this is basically the projection to the end of the month. And basically we can expect the number to just about double. ICU, same thing. It's really just going to keep trending up, but it's a little bit flatter line for what it's worth than what we're seeing with the actual case counts. And that obviously aligns with what a lot of other cities, states, and countries are reporting, is that the case rates are going way, way, way up. The hospitalizations are still going up, but they're not going up as steeply. With our very limited hospital capacity, it's extremely challenging. We're going to go into the assess and refer policy at some point. If Dan Lynch is on, he could probably give you a better date and time about when that's going to happen. But we know that we're going to have to curtail the number of ambulances that are showing up to our emergency departments. And we know we do that very cautiously, because we know that that impacts a lot of people's care, because they depend on the ambulances to kind of get to medical attention. And so we want to do that with utmost caution, but it is a necessary step that we have to do in order to preserve the capacity of the emergency departments and the hospitals. And we're doing a lot of other interventions as we can to help with hospital capacity, including advocating to get more help from the state in terms of staffing, and then supporting testing and medications as much as we can as well. So that moves us into medications. So hopefully you saw the January 4th update that we put out about really how to do medical treatment for Omicron. With most Omicron cases, people are going to be very mildly symptomatic and they're going to be just fine. With people that are more high risk because of age, immunocompromised condition, or other risk factors, they may require, or they may be recommended or eligible for either oral or IV specific medications for COVID. And so this advisory kind of breaks down what those specific medications are and how to go about doing them. We talked about these in depth last week. Hopefully you got a chance to read some of the materials. There's a lot out there. LA County has a really nice summary that I've linked here. CDC has a really nice summary that I've linked here. We put out an advisory last week. They're all kind of saying the same thing, which is that, whenever you prescribe either the Paxlovid product or the Molnupiravir product, you really have to sit down and counsel your patients and think about either drug-drug reactions with Paxlovid or some of the birth defect risk with Molnupiravir. And really have that conversation with your patients so they understand and you have a informed consent and shared decision-making going on. In terms of the actual numbers of medications, it's not that many. We got a total of 160 doses of Paxlovid and a total of 1,000 doses of Molnupiravir, which are due to arrive. We're not even sure if they're in the pharmacies yet, but that's basically a very small number compared to the eligible population who might be deemed high risk. I'll stop sharing this one and then share the actual document that we sent out, just to give you a sense of what that one looks like. And that one is right here. So this document was a January 4th advisory that we were able to release. And then on the second page of this document, this actually has the pharmacies that are stocking these medications. Please correct us if you find any mistakes or a better phone number, for example, or a better way to contact these pharmacies, but we're doing the best that we can with the information that we get from the state. And we know that, communication is not keeping up with how fast things are moving. However, these are the pharmacies that the state has designated to receive either the Paxlovid or the Molnupiravir or both. So you should have this information handy, and you can post it or share it with your staff, etc. In terms of how to actually prescribe or when to prescribe what, that's on the third page. And this basically is to say, eligibility criteria right now needs to be very, very, very narrow because we have so few doses. And really, we need to target the population that's going to benefit the most. And so we really have to steward this resource very carefully. And so we decided to make the age greater than 70 or immunocompromised as the eligibility criteria to begin with. And we can broaden that as we get more medication doses coming into the county in the next weeks or months. Option one is actually the oral Paxlovid. It's easy to do. You just write for it. You check the drug-drug interactions to make sure that there's no major drug interactions. If needed, you have the person stop their other drugs for 3 days, or you make some other contingency plans. And then you can just write a written prescription for Paxlovid and have them take it to one of those 4 pharmacies. And then if the drug is in stock, then they could get the medication. However, you should tell your patients that, the drug may not be in stock because it's so short. Just tell them that up front to set expectations. Second best option is to arrange for them to get either sotrovimab or remdesivir. And those are sotrovimab is a monoclonal antibody that is effective against Omicron. Remdesivir is an antiviral that is effective against Omicron. And so that requires some arrangement, infusion clinic setup, et cetera. But that can be done with help from this document, which we've hyperlinked at the bottom of that orange box. Then the third best option is the yellow box, the oral Multi-Pirovir. Same thing, you have to make sure that the patient understands the risk factors, and you have to really prepare them for some disappointment whenever they show up to the pharmacy and the pharmacy doesn't have this medication in stock. I know that that's really hard. I wish things were different, but that's kind of the reality of where things are right now. So I think that that's really the best practice that we can offer at this time. And then the fourth best option is the other monoclonal antibody treatments, which may not work as effectively against Omicron, but they may help some patients. It's really just taking a gamble. And so that's considered the fourth or the last best option. And then the default option is really just, advising the patients that they just need to self-monitor for deterioration, and really getting them hooked up with a pulse oximeter if you can, so that they can actually start checking their own pulse and heart rate at home, and then come right back if they start to get so sick that it's affecting their pulse oximetry. So that's all included in this advisory, and hopefully you've had a chance to take a look at it. Let me stop there and see if there's any questions about this advisory of what I've talked about so far. All right, and Sim was able to share those advisories on the chat. Let me stop sharing this screen. Joe, do you want to talk about vaccinations and some of the stuff that you're working?
Yeah. Hello, Dr. Vohra. Thank you so much. Dr. Vohra, if you don't mind, I'm going to start with the wastewater results that we've been getting for Omicron and SARS-CoV overall. So I will, really a privilege to be able to come to you and speak to you about really the innovative work being done with in collaboration with City of Fresno, State of California, and UC Berkeley's testing lab as well. So we were approached by the state, I want to say in 2021, about really creating wastewater as a surveillance system for SARS-CoV. And so we really had a lot of questions on the first day, but then we were able to kind of see the research, see the data, and it really made sense. And early on with what we saw in the wastewater testing down in LA County, it was an excellent predictor of an upcoming surge. It would present almost 2 weeks prior to an upcoming surge in LA County, and this was in early 2021. But what LA County did note, though, as their population became a higher vaccinated population, it didn't become a great predictor of a surge, but it did start to really align with whenever clinically you would see cases, the wastewater amount will have a corresponding increase as well. But as the great thing about research is you keep making adjustments, and there's great technology there. Well, now wastewater has become a really significant substantive asset in our surveillance tool to actually look at variants. And so what I'm showing you today is right here on this website. This is available for you to log in right here, data.covid-web.org. This is all the wastewater sites available in in California here. As you can see, the counties that are participating in this wastewater study, and you can see I have it, the dates of when I want the scale here. I'm putting a linear scale, and what we're seeing now for our wastewater results, this is an indication of COVID being present in wastewater. So City of Fresno is the only participating wastewater right now at this time. And so we take it from the main effluent before it goes into any type of treatment. We know that once we actually let the wastewater go into any type of treatment, the methodologies, the detection really significantly is depleted. So this is at the raw effluent stage. As you could see with the dates here, this is the gene copies per milliliter here. You can kind of see where we're going. Notice the sharp curve going here. December 27th, we had about 200.84 gene copies per milliliter. And then right after the holidays, notice where we're at, almost at 1,100 gene copies per milliliter. This is a significant increase here, but this is only telling us exactly just COVID in general is present in wastewater. I'm going to click over to the variant, the subtyping that is being done. And I want to make sure you're able to see a graph. It's bar graphs with different black, yellow, and orange. Can you see that now? Yep. Okay, great. So as you can see, the subtyping that is being done in the lab now is we're looking for that wild type of subtype to really indicate Omicron. When you look at the detection level here, 3 is definitively Omicron. So with the red graphs, the red bar graphs here, you're seeing Omicron. Note that this is December 22nd of 21. So, and that previous graph I showed you, December 27th to January, we haven't had the subtyping done. We highly suspect you're going to see a lot more red bar graphs on that particular once it's finished subtyping. And so 2 is an indication that it is nearing Omicron detection, but not yet. What we're seeing is when there is significant rainfall, we're having to run that test twice to do that amplification and to be able to detect it. So this is methodology that is this is science happening as we live today, but it is something that you're going to see when they update this, you're going to see a lot more Omicron. So to really reinforce Dr. Vohra's comments, Omicron is here. It is highly present. We're seeing that definitely with the wastewater detection that we're seeing. And once we get this updated here and able to share that with you, we will. But it is a great asset in our surveillance tool overall now. So, for vaccines overall, we're at 55% fully vaccinated of our total population. Of our eligible population, 5 and over with 1 dose, we're at 67%. We really have been focusing on booster doses. During the month of November, we were only about 23% of our daily doses were actually booster doses. During the month of December, that went up to 50%, as high as 54%. And so that was really good to see booster doses happening in December. But what we've seen in the first week of January, that is down to about 48% of our daily doses are booster doses. The amount of daily doses we're doing in Fresno County is about 2,600 daily doses at this time. Our 5 to 11, we have about 70% of our 5 to 11 population with 1 dose of vaccine. That's about 19,200 doses administered to the 5 to 11 population. In our 12 to 17, 1 dose, about 59%. What we noticed in the 5 to 11 these past couple of weeks, significant slowdown in the 5 to 11 population being vaccinated. Extremely concerning to us. What we've seen with the vaccine response, it's all about momentum. And we've lost the momentum to the 5 to 11s. We will continuously drag in this population unless we're able to really ignite and change people's minds of where they're at on vaccinating their children. That's why you're seeing you're seeing a lot of different campaigns coming from our health department. We have a social media, TV, radio campaigns on a generations focus. And that generations focus is really normalizing vaccines. We've had vaccines available for decades. It's helped us with polio. It's helped us with so many other diseases. And really the time, we have to protect the legacy, but also we have to protect our future generations with getting them vaccinated now. you're seeing that. The next piece is decisions. We're really going to focus on parents having a conversation with their child about getting vaccinated. Children have opinions about getting vaccinated, and we're really inviting parents to have conversations with their children about that. You're going to see a lot of focus this month, next month, into the 5 to 11 in the adolescent population being vaccinated there. Right now in our freezers, we have ample supply to support you and any type of request you have for any of the vaccines. Just really reach out to our distribution team and we'll be able to support you and feed you out of our freezers. If you have a delay in your vaccine or you can't order one of those big bulk orders, we can go ahead and actually give you vials if need be. If you just need 2 or 3 vials, we're able to support you in doing that as well. Give you a sense of how many pediatric doses have come into Fresno County. 75,000 doses have been sent into Fresno County. That's through the federal and the state program. But we've only administered, what did I say earlier, 19,000? There's a lot of supply in the Fresno County system somewhere in somebody's freezer, right? So it just gives you an indication. We've got a lot of work to do in our 5 to 11s. We continue to do mobile clinics. That's on our website to support any type of mobile clinics. But we are going to start narrowing that down to vulnerable populations in our unvaccinated areas. We're doing a lot with our school districts right now as well. So we really want to focus really on our pediatric population as well right now. So Dr. Vohra, that is it for my updates. Thank you very much.
Great. Thanks, Joe. Appreciate it. Any questions for Joe while we're on the topic? I think that the wastewater surveillance data is really useful, not only now, but hopefully in about a month, people are going to ask, is the surge over? And is Omicron done with us? And I think that the wastewater surveillance will also be helpful for that, because we should see kind of a dropping off of that surge as well. So it's really a cool technology and it's super useful and it's free from the state. So we're happy to have that tool in our toolkit for our surveillance purposes. I'm going to share something about the home testing, and I know this is something else that you've been working on, Joe. So I don't know if you want to discuss this program and how this is going.
Yeah, thank you, Dr. Vohra. So you're getting hearing a lot of news about, we can't live without an at-home OTC kit, right? So as of right now, Fresno County, we've been allocated 84,000 self-test kits. We are reserving those for the vulnerable population, and we're developing different pipelines to distribute that. The first pipeline that we've worked with is our community-based organizations. There's so many in our community have signed up who will pick up test kits and then deliver them to our vulnerable neighborhoods. The second pipeline that we developed will be this website here. This will be made active as soon as we get tests arriving in our basement, or we actually get an actual ship date on when we're going to receive those kits. These will only be available to individuals who live in the vulnerable zip codes. There are 32 zip codes. You can see that off to the right there. The way we determine these zip codes, we looked at our health priority index, quartile 1, our most health vulnerable, and also our most impoverished zip codes in Fresno County. In addition to that, they also met a COVID infection criteria as well. And so these 32 will be the only ones that will, any resident in this program living at this address could actually request kits. We're going to limit it to each kit contains 2 tests. So we're going to limit 5 kits per household every 14 days. And that's how we're going to roll out this program in the first 30 days. We'll reassess supply inventory and see what that looks like. We could add zip codes later. We could decrease the amount per household. We can make adjustments as we see this program kind of roll out. So this will go live as soon as we get an indication on where we're going to get our kits. So this is our second pipeline. The third pipeline we're building, and just got off the phone with the Restaurant Association, they're going to become distributors for us. So we're going to have 4 sites in Fresno County. We're going to coordinate with the Restaurant Association. These at-home kits will actually go for restaurant employees only. It's not to go to their patrons, but strictly to their restaurant employees. So that's the third pipeline we've developed and be ready to launch as soon as we get those kits. And the fourth pipeline we're looking at is in our California Children's Services Program for vulnerable, medically fragile children. we're going to look at that list and really identify children in homes and be able to get kits out specifically to that vulnerable population there as well. So that is what we have going at the OTC self-test kits, getting that distributed out. You heard about the school districts. They received some kits as well, and they've got them out, actually going out to districts today. So hopefully if you have a school-age children in Fresno County and it is a public school or a charter school connected to a public school, they should be getting their kits today and tomorrow, and hopefully getting it out to you in the following days. The private schools, we are working with the superintendent of schools to identify those schools and see if there's any way we can support their efforts as well. And that is it for the OTC self kits, test kits as well, Dr. Vohra.
Okay, great. Thank you so much. Any questions about that program? Awesome. So I see.
You know, Dr. Vohra, if I can remind everybody, you as a medical provider, if you want, you are available to collect, to receive CLIA rapid test kits. And so that usually is either a Binex kit or Care Start kit. And so you can submit a MOOC request. Our team will get that link out to you, but you could request that today. If you want any CLIA approved rapid test kits, and that can be done in the office. These aren't the OTCs to be mailed at to home to your patients. These are actually to be done in the office. So you actually have that capability now to receive those kits.
And you can just email the Mohawk, right? Sim can.
Yes.
Sim will drop that email address in the chat just in case you need it.
Hey, Dr. Vohra,
Yeah, what's up?
what are the instructions? I know that there's instructions once the kits are available on how
Okay,
to
yeah.
administer them, but if you're giving 5 tests to a household every 14 days, what instructions are you giving to this at-risk population of
just-
when to actually test?
Put it into any orifice. It doesn't matter. And, basically.
No, great question. On our, so the boxes come with instructions, but we also have our website actually has a video and has instructions on how to administer the test for the OTC. So
No. I mean, if you give the test to a vulnerable family and they're all feeling great and they don't have any need and you give them 5 tests, how do you tell them when they're supposed to actually do the tests?
Yeah, so this FAQ is basically like a train the trainer model. So we're really relying on our CBOs, our community-based organizations. They're the ones that, for the last 2 years have really worked with these populations, answered their questions, made sure that they understand the risks of COVID, made sure they understand where to get tested, where to get vaccinated. We're really relying on them to communicate the good instructions related to testing, how to do it, when to do it, et cetera. And so this is the train the trainer model that we've set up, and we're developing FAQs, and we'll be developing other educational materials like Joe said, to really train them up to then teach the vulnerable populations and the families. Same thing with the schools. The schools are really struggling with this too. And we had a really good conversation with the schools yesterday to say, we all need to be on the same page because, we can't have one district requiring entry tests and another district not, because that's really going to confuse everybody. So there is a movement to kind of make it a little bit more harmonized as much as possible during this very confusing time to that parents know exactly when to test their kid. My personal opinion is that you shouldn't test asymptomatic people unless they really have a high risk because of close contact or because they're required to because of work or travel. Because otherwise we're just going to burn through kits for no good reason. So you really have to have a good reason to use a home test kit. It's a limited resource, and we'd hate to go for the first 2 weeks and burn through all of our test kits and still have 2 to 4 more weeks of this surge, and then there's no test kits to be found anywhere. So I'm trying to tell people, use these wisely and really deploy them only when you need them. If kid A is sick in your house, then kid B and C, if they come down with the sniffles, you probably don't need to get them tested, right? I mean, just assume that it's Omicron because that's basically how contagious it is. And so basically having those sorts of pointers, we know that parents aren't clinicians. We don't expect them to understand all of the nuances of this, but the basic contours of when do you need to test, I feel like, yes, there is room to do that education. And so insofar as you can teach your families and the families of your staff, that would really help a lot. And we'll try to push out, simple one-pagers about who to test and when to test. But this is one of the FAQs that we're developing right now. It's just in a draft form, so I'm not sure that it's ready to deploy today, but this is, basically what do you do, when do you test, and then what do you do if it's positive, kind of thing. I think the actual kits are pretty easy to use, from what I've been told. And there's not just one company, there's like a lot of different companies that are going to be sending out tests. So we don't even know which testing kits are going to which families and which staff and things like that. But the instructions are, they're on each box, and then the general instructions are going to be like in the YouTube videos and stuff like that. There's some talk about, I guess people are going around swabbing their throat and then swabbing their nose and then running the test. And apparently, that's definitely not what the FDA expects or wants to happen, and probably not something that any of us do on this call, but it's out there. And so our patients are doing that. I'm not sure if it ruins the test or if it makes it, somehow unreliable. But I've seen some headlines that say, please don't swab the throat. These are nasal tests for a reason, and you should really just be swabbing the nose. You're really not even trying to look for people that have COVID. You're just looking for people that are contagious. You really, that's what these rapid antigen tests are answering is this person shedding viral particles right now so that they're contagious? And basically that's where the sensitivity really shines, is when people are symptomatic. And so it really doesn't pick up asymptomatic infected people that well. And so those are some of the pointers that we need to share with the public, is to let people know that, this only works if you're symptomatic or if you have a high risk of having COVID because of close contact. And otherwise, this is not a great reliable test for otherwise asymptomatic people. All right. Any other questions or comments for that? Thank you so much, Joe. That was great. I'm going to go back to the chat and go through some of the chat questions. I feel like there's a lot of questions related to testing of staff, so I'll just go through and try to answer as many as I can. We still have lots of time left, so I think it's a good time to pause and answer these questions because they're really good questions. If a patient tested with a rapid test and then PCR, and the rapid test was negative, but the PCR was positive, what does that mean? That can happen for a lot of reasons. Sometimes the PCR stays positive a long time after somebody's already recovered from an infection. And so for that reason, the person's no longer contagious, like I said, but they may still have just some RNA in their nose. That's the most likely scenario of why a rapid is negative, but the PCR is positive. There's other reasons why the PCR might be positive. It's just a more sensitive test. So if the person's just doesn't have a lot of RNA in their nose or viral particles in their nose that the antigen can test, then that would also mean that they're acutely infectious, but not that contagious. And so that's why the PCR is positive. Right now, people are saying you don't always need to follow up an antigen with a PCR for every single purpose. If the PCR is positive, if the antigen is positive, just count it as a positive. If the antigen is negative and they're otherwise not at high risk, then you don't necessarily need to get a PCR. There's a couple questions about boosters. So after somebody gets a booster, how long do you have to wait before you stop treating them as if they're not up to date? And the answer is about 2 weeks. So after two weeks after your shot, really of any shot, is when your immune system is really thought to be fully mature. And so really 14 days after somebody gets a booster is when they are then considered up to date with this new mandate. And it is a new mandate. If they want to decline a booster, they need to get some kind of an exemption like they did the first time around. Otherwise, they will need to get a booster because it's mandated now from the state that all healthcare staff get their boosters. And I think February 1st is the deadline, although I have to go double check the documents, but it's somewhere in that time frame. They still have a few more weeks left, but they need to make arrangements to get their boosters as soon as possible. If the antigen test is positive, do we still need a PCR confirmation for regulatory purposes? No, you do not. If the antigen test is positive, please report that into your CalReady. or contact us to let us know. Otherwise, you don't need to get a PCR test. Is the quarantine 5 days or 10? Yeah, that's a good question. It kind of depends on who you're asking about, because they've really got, it could be 5 days, it could be 7 days, or it could be 10 days. For the general public, it's 5 days. For healthcare workers, it's 7 days plus a negative test. For congregate settings, it's still 10 days. So that's the short answer. And I can share some links out to explain more. But congregate settings means, like, you know, residential inpatient settings, psychiatric facilities, jails, and also any like juvenile youth settings as well. So this has come up because we do have an outbreak in one of our juvenile settings, and we did have to look this up, and the quarantine period is still 10 per the state. So with all the home tests, can we have any confidence in the number of new cases? Yeah, because that's a great question. The answer is our confidence will be a little bit diminished by the fact that we know that people will test at home. The instructions right on the pamphlet and right on the box tell you, if you test positive, you need to report this to your local health department. A lot of them have apps and QR codes and websites that make reporting pretty easy. However, we know that people aren't going to take that extra step. They may go into full-blown panic mode. They may just forget, et cetera, if that test comes back positive. So we know that they're possibly not going to report that home test if it's positive. They're definitely not going to report if it's negative. And so that's just, it's understood that that's what's going to happen. So just keep in mind that, you know, the number of positive cases that are being reported, and this is like worldwide at this point, you know, we know that home testing is just notoriously underreported. And that's just kind of where we are. We're just hoping that, you know, we get a better signal from what's going on in the emergency departments and the hospitals, because at the end of the day, that's really why we're doing so much testing, is so that we can make good decisions about how to use our very limited healthcare resources. And then obviously organizations would like to know, because they want to keep their folks safe, and they really want to know, if you tested positive at home, then obviously your employer wants to know for a lot of good reasons. An employee in a doctor's office is refusing to take the weekly antigen test because the swab contains traces of ethylene oxide. Yeah, so this has raised its head several times. The ethylene oxide is really used throughout medicine as a sterilant. It basically is, it's a great killer of germs. And so it's used as a sterilant and a preservative in all kinds of stuff, you know, medical instruments, endoscopy, colonoscopy, et cetera. The great thing about ethylene oxide is that it really, very small amounts are used to begin with, and it kind of evaporates. So it's not in the swab at the time that the swab goes inside somebody's nose. So it's like, if you are exposed to large amounts of ethylene oxide every single day, then yeah, it is a carcinogen, and it has some health risks for chronic exposure. But the ethylene oxide exposure is nil from these swabs. And so people are just kind of, you know, misreading the fine print on how these swabs are made. And this has been debunked many times. I've actually shared a link about the websites that debunk this. But, you know, if it comes up to say, you know, people are really scared because ethylene oxide is inside the swabs and they don't want to get swabbed, that is not a good excuse for not to get swabbed. All right, and then a question about, do we have any information on facilities interested in helping with monoclonal infusions? It's very tight. We know that it's very tight right now. There's a lot of reasons for that. First, the actual doses are very low compared to the need. We know that the sotrovimab, which is the preferred agent, they're not giving us very much at all. We're obviously trying to facilitate as much as possible, but that's probably the number one reason why you're running into frustration and hearing about frustration related to the infusions. A second reason, which is a little disappointing because this is on us as a medical community, is that we really haven't done enough to provide clinical space and invest staff into doing these infusions, which we know prevent hospitalizations. And so this is really something that as a system and at the organizational level, we really just need to really just, have these conversations to say, how could we invest staff and space into doing this? We know that things are really tight and short, but unless we do this, it's not going to get done. And so that's not the same as having no medication, which is the larger issue. But whenever there is medication, we also hear stories that, for whatever reason, X, Y, or Z organization doesn't have the staff to infuse these monoclonal antibodies. And that's really frustrating too, because, unfortunately, those patients might go on to have like an ICU stay, which will require a lot more staff. So we just have to work with the resources that we have. Is there going to be a change in quarantine time for an asymptomatic person who tests positive? So the isolation time, so whenever you test positive, whether you're symptomatic or not, you're no longer quarantining, you're isolating. And the isolation time has already shortened to 5 days. I don't know that it's going to shorten any more than that. So I think that that's here to stay. For the general public, that is what it is. For healthcare, depending on if the healthcare organization is in kind of crisis standards or not, they may allow that person to come back sooner if they're asymptomatic and wearing an N95. And that's outlined in the CDC guidance for healthcare about how to manage staffing during surge. So you could take a look at that. So they do have a little bit of leeway, but not much for somebody who's asymptomatic and then test positive. So yeah, has the county adopted that yet? We're basically just going with the CDPH, and I think the CDPH has aligned with the CDC on the isolation time for healthcare workers. And that's on that link that I could just show you real quick. Hang on. So this is, I'm looking at the work restrictions related to healthcare personnel who have an infection. Sorry, let me share this. And right here it says, work restrictions for healthcare personnel. So this is CDPH. And if you scroll down here to the first table, this is what they're saying for people that have an infection. So if they're boosted or vaccinated and not yet booster eligible, then 5 days and a negative test to come back to work, or 10 days without a test. And if there's critical staffing shortages, like I said, if they're in crisis mode, then you can go down to less than 5 days, but you still have to have a diagnostic test. Okay, so that's basically, they basically lifted the same criteria that the CDC had for healthcare workers. They also put in a negative test for the general public as a return to work criteria. Okay, any other chat? I think I went through all the chat questions. Yeah, so for Kevin, the test has to be an antigen test. So again, this goes back to contagiousness versus infection. So when they say a negative test to come back to work, it's a negative antigen test, which would prove that that person's not shedding a lot of viruses. And so that's what the expectation is. They really don't want you to do a PCR on an infected person because we know, like you said in your comment, that it will stay positive for up to 90 days. Okay. If they decline the booster, they still need to test ×2 a week, yes. That's my understanding. According to the new HCP guidelines, why is it that a vaccinated individual and a booster eligible are in the same category as the unvaccinated? I don't know if I can answer that off the top of my head. I don't know what their reasoning was for the criteria that they came up with. Yeah, that's a good question. I'm not sure. Do we have to have an observed negative antigen test to come back to work? Yeah, that's a good question. You know, I think that would be ideal. Really, you're asking a question about, you know, trust and things like that. So it's hard for me to answer for every single situation. But yeah, I mean, I think that would be ideal, is to have, you know, some kind of a staff person document a negative test. But I don't know if it needs to be observed per se. It's not really delineated in any of the guidance. Has there been a meeting with the schools to clarify the new criteria? I've been told by a few parents when one child is positive, the other can still attend school. Yeah, I don't know. You know, you're asking about quarantining kids versus keeping them in a period of quarantine and direct monitoring. I'll have to get back to you on that one. If you want to email us, Dr. Zweifler works with all of the schools and the school nurses on everyone's protocols. So he may be best poised to answer that one. And then if the school district is not quite doing what's the safest, then that's actually a great opportunity for us to do some education and have some conversations with them. So if you want to email us the situation, then we can follow up on that offline. And then, yeah, if you need rapid tests from the county, just email the Mohawk. All right, good stuff. Great questions. Let me just finish up a couple more items as we're coming down to the last 10 minutes. And then I'm happy to stay on if people have other questions or comments. So we talked about the January 4th medication advisory. We talked about the safe test kits. Really just a few other items that are not even COVID related, but still super important. First of all, Happy New Year for those that I didn't say that to before. And with the new year come new year resolutions. So I really want to, you know, even though we're all kind of just keeping our heads above water with COVID, be mindful of the other public health issues that we all need to be aware of. First, there is just a tremendous blood shortage. So please, please, please donate blood. Tell your staff to donate blood. Tell your patients who are healthy and able to get blood donated, and tell all your friends and family as well. This is a huge need. You know, Chris is on, and hopefully Chris can unmute and talk about this. But you know, he shared with me that out of all the people that are eligible to donate blood, only 3% do it. And so even if we move that to 5%, that would be a huge number of new donors that the blood center definitely needs. I worked in the trauma zone last night. We were just giving transfusions right and left because they were needed. I mean, these trauma patients, they really just soak up so much blood at our hospitals. And we know that, you know, many other kinds of patients, not just trauma patients. And you know, it's like we're trying to conserve every single unit we have, but we absolutely need it to keep people alive. And so this is really critical that all of us are aware of how dire this shortage is. This affects all of our patients, and it will eventually affect all of us, because you really can't even go to surgery for any reason unless there's blood available just in case, quote unquote. And so, you know, sooner or later, all of us are going to need blood available. So this is just a dire community issue, and we're really working with all of our neighboring counties to try to raise the awareness about donating blood. Go ahead, Chris.
Thank you, Dr. Vohra. Well, you said it really well. So thank you for being such a great advocate for blood donation. And also I want to thank all the hospitals in the Valley. Their blood transfusion services have been extremely patient with slow inventory that we've seen. And every day when we label another batch of O's, we really have to ration them out to each hospital according to how many we have and according to how many are needed out there. And as I said, the hospital transfusion services staff have been extremely understanding and very patient, and I'm sure they're under a lot of pressure from the the care providers to get that blood, and so it's just a national phenomenon. It's always a little tough this time of year, but we're still seeing a lot of effects from the pandemic and supply shortages of all kinds, and that's also a blood shortage as well. So again, to keep it on everyone's mind is very important, and to just keep talking it up and urging people, everyone in your network, urge them to donate blood. All types are needed, in particular type O, but every type is needed right now. So thank you all.
Thanks, Chris. A couple more items. This is something that I'm going to message about quite a lot, but just to put it on your radar, we have a huge epidemic related to infectious diseases that are sexually transmitted, that are chronic, and really impact the quality of life in our patients, and really sap a lot of resources in our healthcare system. That includes the STDs, hepatitis C, and HIV. And the real tragedy is all of these are very preventable and treatable as long as they're caught early. They're catastrophic when they're late, but in the early stages, there's actually so much that we can do now for all of these diseases. And so universal screening makes so much sense as an investment in our healthcare system. Please make this a part of your practice for patients that are sexually active, of childbearing age, at risk due to their drug use, et cetera. Please implement some kind of a protocol to where it's almost automatic and that your staff is used to that culture where we just accept that unfortunately this is in our community and that we destigmatize these conditions as much as possible, that we test. Just like with COVID, testing is really one of the layers of protection. And we really have to test for these diseases in order to find them. And once we find them, we can get people started on treatment. Even hepatitis C, which was such a life sentence just a few years ago, now is very treatable as long as we catch people early. And so please make a point this year, make this a New Year's resolution that we can actually put a dent in these epidemics and let us help you. Like I said, I've already told my team, we need to make this a top priority, even aside from COVID. And so we're going to be unrolling several programs and campaigns throughout this year related to this issue. But we'd love to have your help and your ideas about how we can do this. And I look forward to talking more about that. And last but not least, I couldn't let you get away without hearing about getting your X waiver. So this is another great New Year's resolution. This only takes 5 minutes. The X waiver allows you to really just level up your ability to take care of patients that are struggling with substance use disorders, especially opioid use disorder. And the X waiver, you can go on a government website and sign up for it today. It only takes 5 minutes, and then it will basically be ready for you to use in about 6 weeks. And once you have your X waiver, you can start treating people with medication-assisted treatment, which is also known as Suboxone. And the Suboxone really keeps people from dying of opioids. Opioid deaths crossed 100,000 last year. It's the first time they've ever been in the 6-digit range. But that's basically the era that we're living in now, is that, aside from COVID, this is definitely claiming a lot of lives. And it's something that's entirely treatable if people knew about Suboxone. This prevents people from going into withdrawal, prevents cravings. It really helps them regulate all of their brain chemistry and hold down a job and go to school and do all the other things that are fulfilling in life. It really is a life-changing medication. I've seen it do wonders in the patient population that we serve. And I really just want to share, you know, the power that it has. It's a great medication. Unfortunately, the government makes us get this stupid X waiver. I wish that wasn't the case, but it is. So let's get it done so that we can help our patients. I'll speak more about that, you know, in the weeks to come as we get through this COVID surge. We'll have time to talk about these other issues, and hopefully we can all get waivered together because it only takes 5 minutes, and we can even do it over Zoom. But if you're interested in doing it now, I'll include the link in the instructions so that you can start your new year with a new waiver and hopefully, you know, acquire a new skill set that definitely helps to save lives. This is one of the most impactful things that's ever happened in addiction medicine is medication-assisted treatment, which is why you're hearing so much about it. And it's really something that we need to be doing more of here in Fresno County. All right, those are all of the updates that I have. Let me see if there's been more questions in the chat. And we will definitely share out this set of notes with all of the links for you to look through. I know there's a lot going on. You know, like I said on my media session yesterday, we don't have a roadmap, but we do have a compass, and we know what the best practices are to get us through this very challenging time. And hopefully we can just convince, you know, all of our patients to really implement these best practices that have been proven to work over the last 2 years, including getting your boosters, using the masks, doing testing in an intelligent way, and doing the quarantining and isolation as needed. So even though we don't know exactly what lies ahead, we have a pretty good idea of what we're in for. It's going to be a very challenging month. So just, you know, pace yourself and brace yourself, but we will get through it, and we're happy to support you. Just reach out to us if we can help with anything. Thank you so much. Naomi, I see your question. If a medical staff member had a positive PCR, do they need to be retested? I would retest them on day 6 with an antigen test. If you retest them with a PCR on day 6, chances are the PCR will still be positive, and then they'll need to stay out till day 10. But if you retest them on day 6 and it's negative with an antigen test and they're asymptomatic, then they can come back to work. And that's in the guidance that I shared with the CDPH. All right, thank you, everyone. Really appreciate all these questions. These are really fantastic. Sam, if you could just copy paste all these questions, and then we can actually share these with the answers whenever we put out the notes, and I'll work on that. All right, thanks, everyone. Take care.
Thank you.
Bye.
Thank you, Dr. Vohra.